Awesome. So, hello everyone. Thank you for joining me today. My name is Julianne Fallon, and I'm a PGY1 pharmacy resident at the University of Virginia Health System. Today we're going to be talking about acute coronary syndromes. So specifically, we're going to cover a few things. One of these is looking at the different presentations of different types of acute coronary syndromes, such as unstable angina, non-ST segment elevated myocardial infarction, and ST elevated myocardial infarction. We're going to talk about kind of these key time frames that are associated with management, as well as pharmacological treatment for the acute setting and the long-term outpatient setting. So first, to start off, let's talk about what acute coronary syndromes are. Really, this is an umbrella term that encompasses various conditions where blood supply to the heart is suddenly blocked. So this can be something like an acute myocardial infarction, which you may have heard referred to as a heart attack, and that could be classified as a STEMI or NSTEMI. So like we discussed on the previous slide, the ST segment elevation or non-ST segment elevation, as well as the condition known as unstable angina. We'll get into a little bit more detail on what differentiates all of those conditions a little later in the presentation, but just that for now. And then going to acute coronary syndromes in general, these are very common occurrences, and cardiovascular disease is one of the leading causes of death in America. And when we look at just the incidence of MI, an American experiences an MI approximately every 40 seconds. So as you can see, this is a very prominent condition that a lot of people will experience. So it's important to know when you're encountering patients experiencing this, how to handle their care. So what causes that sudden blockage in the heart? A process known as atherosclerosis results in plaque formation. That plaque is full of inflammatory cells and cholesterol and just all sorts of bad stuff that's just building up in the arteries. Over time, the arteries start to narrow because that plaque is getting bigger and bigger. And that narrowing results in decreased oxygen circulation. And then at a certain point, that plaque can actually rupture, leading to an infarct. And that infarct is really this sort of conglomeration of cells, those lipids, the inflammatory cells, that cause an acute occlusion of the artery. And that may result in things like stroke, heart attack, or death. So not great things. So today, this is kind of our template for what we're going to be walking through in our discussion of acute coronary syndrome. So this is the American Heart Association algorithm for how to handle patients who are presenting with acute coronary syndromes. So first things first, we need to learn how to recognize patients who are experiencing an ACS. So they're experiencing these symptoms that are suggestive of ischemia or infarction. So what does that really mean? Patients typically will present with chest pain or discomfort, and this chest pain is so severe that they may describe it as something very constrictive, even to the point where they feel like an elephant is sitting on their chest. So nothing to sneeze at, very extreme pain and discomfort. Similarly, they may have pain or discomfort in other areas, such as the arms, the jaw, neck, back, or stomach. They may also have shortness of breath, feel dizzy or lightheaded, nausea, and sweating. Now, when you think about these symptoms, you'll notice that a lot of them are fairly vague, and they could indicate something else is going on. But what's important is if you start to see these kind of typical symptoms suggestive of ischemia, you should call 911 and get to the hospital right away, because it's better to rule out that this is happening rather than to sit and wait on it. So now we'll talk about the acute treatment of acute coronary syndromes. So the first couple steps is, these symptoms have been reported, you've called 911, emergency medical services come to you, and there they decide if they need to, they run various tests and administer supportive care as needed. So we'll kind of talk through what those immediate supportive care and treatments are. We know them by the acronym MONA-B. We'll actually discuss the B portion later with the long-term treatment. And this is for kind of any patient with a suspected acute coronary syndrome. And we'll go into when you would use each of these treatments. And of note, this acronym is not in the order of importance. So the first portion of that acronym is the MONA. We have M for morphine. This is indicated for the relief of chest pain. And morphine, compared to other opioids, has beneficial hemodynamic effects. So it can decrease the heart rate, the blood pressure, and venous return. Unfortunately, though, a lot of data has come out recently that morphine can decrease the antiplatelet response. So this makes it not an ideal agent, as we'll discuss later. We use a lot of antiplatelets in treating ACS. So if we're inhibiting how well those medications are working, that might not be ideal. This medication is typically administered during EMS or ED assessment, just as needed, typically for patients who don't have chest pain relief after nitroglycerin. When we look at reasons you might not want to use morphine besides what I just mentioned, there's also, it can accumulate in renal impairment, so patients with chronic kidney disease, you want to be extra cautious in. Adverse effects are typical of all of our opioids, so you can have changes in mental status, drowsiness, altered mental status, constipation, GI upset, and respiratory depression. So using this medication judiciously. Next we go to O for oxygen. And this is really only indicated for patients with hypoxemia, so those who are not saturating with oxygen as well as may be desired. And this is really thought to potentially, by increasing oxygen saturation, we may be able to improve oxygen delivery to the tissues, leading to a reduction in these ischemic processes. This is really only administered just as needed, and you kind of titrate the dose, per se, in liters of oxygen until patients start satting kind of where you want them, above 90%. And of course, there's not really a lot of evidence for providing oxygen to just every patient, so patients with normal oxygen saturation may not have any benefit. Moving to the N, we have nitroglycerin. This is probably the most common one you'll encounter for patients, and this is really indicated to help relieve chest pain. For the IV formulation, which is something you typically start a little bit after this acute period, but sometime maybe in the first 24 to 48 hours, that's indicated as an acute titration in obvious ACS, objective test abnormality, and ongoing discomfort. So those patients who, after the full kind of set of doses of the sublingual or short-acting form, they may get transitioned to IV to further reduce those symptoms that they're having. How does it work? It's a vasodilator, so that helps kind of dilate these arteries that have potentially been closed down because of this acute event, and that can help to improve the oxygen circulation. And there are some important contraindications to this medication. One of them is hypotension. As I mentioned, it's a vasodilator. So for patients who have low blood pressure, we don't want to dilate them any further because that can cause their blood pressure to drop to an unsafe level. Similarly, we don't ever use nitroglycerin with the phosphodiesterase inhibitors, such as your Viagra, Cialis, etc., because for the same reason, these can cause very severe hypotension. Adverse effects, as we've mentioned, vasodilation, hypotension, headache, and dizziness, all of those correlated to each other. It's also important to use caution in patients with an inferior wall STEMI. And just as sort of an aside, it is important that patients who have the chest pain that's relieved with nitroglycerin doesn't mean that they specifically have had an MI. And these patients should also receive a prescription for nitroglycerin after discharge in case these symptoms occur again. Moving on to the A of MONA, we have kind of our core pillar, and this is going to be the most important treatment for patients who are thought to be experiencing an acute coronary syndrome. It's the only portion of the MONA that's associated with a decreased mortality, and this is our antiplatelet, so working directly on that infarct to decrease the action of platelets. And this should be given kind of as soon as you're suspecting an acute coronary syndrome. Typical dose for the first loading dose is between 162 to 325 milligrams. Typically patients will have the 81 milligram tablets, so they should take 4 of those, chew them up even if it's the enteric coated, to make sure this medication is working quickly. There are some reasons not to take aspirin, and that would be primarily a sign of an active or recent GI bleed, as this medication can cause an increased risk of bleeding, as well as GI upset and GI ulcer, so we don't want to exacerbate that. And it's very important to avoid any other NSAIDs in patients who are experiencing acute coronary syndrome because it really increases mortality, the risk of reinfarction, hypertension, heart failure, myocardial rupture, so nothing good there. This leads us to our first patient case. So we have LS, a 55-year-old male, presenting to the ED with chest pain, shortness of breath, tachycardia, and diaphoresis. His O2 saturation is 96% on room air, and he reports taking a dose of nitroglycerin at home prior to EMS arrival. Which of the following medications should be administered first? it's aspirin, 324 milligrams by mouth once. As we just discussed, aspirin is the only pillar of the MONA that actually decreases mortality. He also had normal oxygen saturation and had already taken a dose of nitroglycerin, so that's not the first thing on our priority list. Next, we'll talk about how to differentiate between the different types of acute coronary syndromes. So the first step is to look at an EKG. In a normal EKG, you have a P wave, QRS, and a T wave. What we look at when differentiating between different types of MI is the ST segment, so the area between the end of the QRS complex and the T. In a STEMI, as you'll see by this second picture on the left side, in a STEMI that area is raised, so a ST segment elevation. And on an EKG, you have to see that in at least two contiguous leads. In an NSTEMI, you don't have the ST segment elevation, but you may have ST depression or T inversions, which are the other two pictures on the left. There also may not be any EKG changes, or the EKG just may be there and then go away, so be transient. So the way to tell between then an NSTEMI and an unstable angina is the release of cardiac enzymes, such as troponin. So in STEMI, cardiac enzymes are released, same as in STEMI. In unstable angina, typically we don't see an elevation of the cardiac enzymes. This leads us to patient case number 2. We have BK, a 50-year-old female who called 911 because she was experiencing chest pain that was unrelieved after taking famotidine. She's now in the ED. She has no remarkable past medical history and has not seen a doctor in the last 5 years. She also reports that her father had a heart attack when he was 54 years old. In the ED, an EKG is performed that reveals the following. You can see that there are peak T waves in leads 2, 3, and AVF. So which of the following is the most likely diagnosis? STEMI, NSTEMI, or unstable angina? And you're correct. The answer is STEMI. We see that there are those peak T waves in at least two contiguous leads. Now that we know the type of acute coronary syndrome the patient is experiencing, we go on to sort of these next step treatments, which can either be adjunctive, so kind of increasing the amount of antiplatelets and antithrombotics we're giving these patients, or it may be reperfusion therapy, such as PCI or fibrinolysis. So going on to acute treatment, continuing on, we have the P2 Y12 inhibitors, which are also antiplatelet agents similar to aspirin that work slightly differently. These are indicated to decrease mortality in patients with STEMI or NSTEMI undergoing PCI or are medically managed. And these can be given either after diagnosis typically, but maybe prior to, during, or immediately after PCI. All of these medications are, you start with a loading dose, and then you go on to a maintenance dose, which we'll look at in a later slide. Of note, 3 of these agents are oral meds, and that's the ticagrelor, prasugrel, and clopidogrel. But there is one that is IV, and this one is cangrelor, which is really primarily indicated during PCI, that may be considered in patients who are unable to take or absorb oral agents, particularly in that immediate period around PCI or when an intervention is occurring. There are some important contraindications to these agents. Similar to aspirin, we have an active bleeding or allergy, but also hemorrhagic stroke. And prasugrel in particular is really strongly not recommended in patients with a previous stroke, transient ischemic attack, patients who are older than 75 years old or less than 60 kilograms. Adverse effects, as you would guess, increased risk of bleeding. And with ticagrelor, you can actually see some transient dyspnea. And then it is important to note that there are some drug interactions to consider with these agents, such as clopidogrel, which has issues with CYP2C19 poor metabolizers in patients taking certain proton pump inhibitors. Moving on to anticoagulation. Some patients may have an indication for this when they're undergoing PCI or medical management. This helps the body. We discussed how that infarct was full of platelets and inflammatory cells. Some of those can form a clot. So these anticoagulants help the body stop making that clot bigger and give the body time to break down the clot. And timing varies based on the indication as well as the agent being used, with enoxaparin, our preferred agent, typically used for the duration of hospitalization or until intervention is performed, versus unfractionated heparin, which is used until intervention or 48 hours, whichever occurs first. Again, there may be some variation on this depending on which institution you practice at. Contraindications, there are a few important ones to note. One is a history of heparin-induced thrombocytopenia, as being re-exposed to heparin can cause this abrupt decrease in platelets and increased thrombosis risk. And that's with any heparin-containing products, including heparin flushes. So if you see a patient with a heparin allergy, it's important, or a history of HIT, it's important to avoid anything that could potentially contain heparin. Active bleeding, as we saw before, and also pork allergy. And then of note also, enoxaparin does need a dose adjustment in renal impairment. Another important class of drugs during this sort of acute stage is actually statins. And these have been found to reduce the rate of recurrent MI, coronary heart disease, mortality, need for myocardial revascularization, and stroke in patients with STEMI or NSTEMI. So they have a pretty strong evidence base for using these to prevent some of the mortality and morbidity in this in acute coronary syndromes. So the statins work by inhibiting the formation of cholesterol by inhibiting HMG-CoA reductase. These should actually be given as early as possible, so within that kind of first 24-hour time frame, and they should be continued after the acute event indefinitely. So for that immediate period, it's important to go with as high a dose of statin as you can, so typically atorva 80 milligrams or Crestor or rosuvastatin 40 milligrams. And then after this acute period, you can drop down the dose a touch, but still within that high intensity. There are some important contraindications to statin use, and this includes intolerance to the chosen statin, acute liver disease, pregnancy, unexplained persistent elevations of serum transaminases, and these medications are really known for causing myalgia and potentially rhabdomyolysis, so always monitoring patients to make sure that they aren't experiencing these adverse effects. Another important point about these statins is that for patients who are already on a low or moderate intensity statin, they should have that statin intensity increased to high intensity as long as they are able to tolerate it. And they should also be started on this high intensity statin irrespective of their cholesterol. So even if they have perfect cholesterol, they should still be started on this statin. And there are some groups that you would consider a lower intensity statin in, such as those who are elderly or have hepatic or renal impairment, or of course potential for drug-drug interactions. This takes us to our third case. We have BK, our 50-year-old female who called 911 because she was experiencing that chest pain that was unrelieved after taking famotidine. After she was seen in the ED, she had an EKG where she was diagnosed as having experienced a STEMI, and her cholesterol panel is all within normal limits with an LDL of 50. So which of the following cholesterol medications should be started? A, none, her cholesterol is normal. B, simvastatin 40 milligrams by mouth daily. C, atorvastatin 80 milligrams by mouth daily. Or D, atorvastatin 40 milligrams by mouth daily. And you all got it correct. It is C, atorvastatin 80 milligrams by mouth daily. As we discussed on the previous slide, it's important to start a statin, high-intensity statin, as soon as you know this patient's experiencing an acute coronary syndrome such as STEMI or NSTEMI. And you would still start it even though her cholesterol is normal. So now we'll switch gears a little bit and talk about long-term treatments after patients go home when they've experienced an acute coronary syndrome. So as you probably guessed, we'll talk about aspirin. This is a really key medication, not only in that acute setting, but also long-term. So it's used for secondary prevention for all patients with a history of acute coronary syndrome, especially STEMI or NSTEMI. Still has that antiplatelet effect, and the dose is a baby aspirin, so the 81 milligrams by mouth daily. And you'll stay on that kind of indefinitely unless there's reasons to stop. for those patients who underwent PCI or were medically managed can be the P2Y12 inhibitors. As you'll notice, we dropped out our IV formulation as we don't use that one long term, but any of the oral ones are kind of up for grabs. And we would have picked the appropriate one based on the patient in front of us to make sure they didn't have any contraindications. And the duration of these is actually really variable. On this slide, we have the kind of guidelines for recommendations for use. And you can see that depending on the procedure that was done or the acute coronary syndrome you went through, as well as your risk of bleeding, you can kind of range anywhere from 1 month to a year or more than a year. So it can be very patient specific how long these patients will be on the medication. So next we'll talk about beta blockers. This is the last portion of MONA B, so the B in MONA B. These are indicated to reduce the risk of death, recurrent MI, and hospitalization for heart failure in acute coronary syndrome patients who have a left ventricle ejection fraction less than or equal to 40% and or heart failure after stabilization. These work by decreasing the heart rate, the blood pressure, and contractility, providing a lot of beneficial hemodynamic effects for these patients who have just experienced an acute coronary syndrome. These should be administered within the first 24 hours after diagnosis once the patient is hemodynamically stable. The beta blockers that we see used for this indication are those that we see in patients with heart failure. So you have metoprolol succinate, so the extended release form. You have carvedilol, known as Coreg, as well as bisoprolol. The two you'll see most commonly at UVA include metoprolol and carvedilol. The duration that patients will be on this medication can vary, but is typically indefinitely unless there's a contraindication to their use or patients aren't able to tolerate the medication. There are some contraindications, including acute heart failure, hemodynamic instability, and AV block. Adverse effects: since this medication decreases the heart rate, you can have bradycardia, and since it lowers the blood pressure, you can have hypotension, dizziness, fatigue, and weakness. The next class of drugs we'll discuss are the ACE inhibitors. They have a similar indication to what we just saw with the beta blockers, but they can reduce the risk of hospitalization and death in acute coronary syndrome patients with evidence of left ventricle ejection fraction less than or equal to 40%, heart failure, hypertension, diabetes, or stable CKD. They work by inhibiting the angiotensin converting enzyme, or ACE, which prevents conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor, so by inhibiting the formation of angiotensin 2, we have a lot of favorable, again, hemodynamic effects for these patients, especially in those patients with conditions like hypertension, diabetes, or stable CKD. These should be administered also within the first 24 hours after diagnosis, once the patient is hemodynamically stable. The most common ACE inhibitor you will probably see used is lisinopril. That's what we see pretty much every day here at UVA. But there are other ones out there. You can recognize them because they end in pril. There's benazepril, captopril, tasinopril, enalapril, quinapril, and ramipril. There are some contraindications with these, including a history of angioedema with another ACE inhibitor or with a different class, as well as pregnancy. Adverse effects: very commonly these can cause hyperkalemia, hypotension, and an increase in the serum creatinine initially for patients. So important to closely monitor them when you're starting them on this medication. And some patients may not be able to tolerate an ACE inhibitor, so you could use an alternative known as an angiotensin receptor blocker, or an ARB, which kind of works in a similar way, inhibits the formation of the angiotensin 2. And common examples of those are losartan and valsartan. Here again we talk briefly about the statins. Important for these patients after they've experienced an acute coronary syndrome to continue on that statin to kind of help again with secondary prevention. High intensity statin is preferred in the patients who can tolerate them. Next class of drug we'll discuss are the mineralocorticoid or aldosterone receptor antagonists. These are indicated to reduce the risk of hospitalization and death in acute coronary syndrome patients with evidence of left ventricular ejection fraction less than or equal to 40%, heart failure, or diabetes. They work by kind of selectively antagonizing the aldosterone receptor, and these can be started once the patient is hemodynamically stable. And this can be a little bit longer after that 24 to 48 hour window. It just depends on the patient and how stable kind of their renal function is and their electrolytes. We typically use either spironolactone or eplerenone. And again, there are reasons not to use these agents, including patients who have hyperkalemia, so a potassium that's greater than 5 milliequivalents per liter. Typically not a good idea to start it in someone whose K is that high, as well as renal dysfunction, so patients who have a serum creatinine greater than 2.5 in men or greater than 2 in women is what's recommended, but I would typically use a lot of caution in anyone with a serum creatinine over 1.5. Common adverse effects include hyperkalemia and GI upset. With some of these medications, particularly spironolactone more than eplerenone, can cause gynecomastia and breast tenderness. So this leads us to our final patient case. We have BK, a 76-year-old male with a past medical history of diabetes, hypertension, dyslipidemia, stroke, and COPD, who originally presented in the ED with a chief complaint of chest pain. He was diagnosed with an NSTEMI and admitted to the hospital, where he was given a loading dose of aspirin and ticagrelor. His most recent echo shows that his ejection fraction is 25%. His blood pressure is 165/84 millimeters of mercury, and his morning labs are notable for a K of 5.5, his serum creatinine of 1.5, where his baseline is normally 1. Which of the following would be appropriate medications to start in PK? Lisinopril, 5 mg by mouth daily, carvedilol, 6.25 mg by mouth twice daily, prasugrel, 10 mg by mouth daily, or spironolactone, 25 mg by mouth daily. So you may have guessed it, but it is carvedilol. Based on his potassium and serum creatinine, it's probably not safe to start him on lisinopril or spironolactone quite yet. He also had a recent history of stroke at the beginning of this year, so prasugrel is really not a great option. His blood pressure is a bit elevated. I didn't give you his heart rate, but we'll say it's normal, somewhere in the 80s, so he's perfectly safe to start on his carvedilol, 6.25 mg by mouth twice daily. So this kind of concludes all the treatments we'll talk about today. I just want to reemphasize that it's important that there is rapid action when an acute coronary syndrome is suspected, as this can kind of help decrease mortality when we get these treatments started quickly. Acute treatment modalities for acute coronary syndromes help resolve symptoms and can reduce mortality, and our long-term treatment options help to reduce cardiovascular risk factors, and they really kind of act as the secondary prevention way, so reducing the risk of death or hospitalization for another acute coronary syndrome. Here are my references, and thank you for joining me today.